Welcome to Section 1 of Cardiovascular Anatomy. In this section, we will discuss the arteries of the upper body, including the head, neck, and upper limbs. It's important to know that anatomy for board exams is tested using pathology. What this means is that you need to know relevant pathology and be very familiar with the anatomical structures involved. Now, this table shows the arterial anatomy for the upper limbs as well as the pathology that you need to know. So we're going to start with the subclavian artery. This image demonstrates the arteries for the upper body that you need to know for step 1, and it can be found in section 1 of your cardiovascular anatomy text. So diving right in, from the heart, the aortic arch will ascend up and then descend down. Now there are 3 major vessels branching from the aortic arch: the brachiocephalic artery, then the left common carotid artery. You can see the common carotid arteries labeled here, and then the left subclavian artery. On the right side, the brachiocephalic artery will split into the right subclavian artery and the right common carotid artery. So now, if we draw our attention just to the left subclavian artery, we will notice some important branches. For example, we have the vertebral artery branching off from it, and this will ascend up to the brain. Now, this figure is found in the Physiology Neurology chapter, the section on the neurovasculature. Notice how both the vertebral arteries, we can see them labeled here, will converge to become the basilar artery, which you can see is labeled. An important pathology that highlights the subclavian artery anatomy is something called the subclavian steal syndrome. In this condition, there is occlusion of the subclavian artery proximal to the vertebral artery. So for example, right here. Therefore, on this side, there will be decreased blood flow to the vertebral artery. However, on the other side, the subclavian artery is well perfused. So we'll see blood traveling this way, and it will travel up the vertebral artery as normal. And normally the vertebral arteries will converge, so this blood flow will actually reach this intersection, and because the vertebral artery on the opposite side has such low pressure, blood flow will actually go down this way. And this is the reverse of its normal flow. So blood that would be traveling to the brain through the basilar artery will actually be traveling through the subclavian artery and to the limb. Going back to this image, a block here in the right subclavian artery would result in decreased blood flow to the adjacent vertebral artery, so the opposite vertebral artery will compensate and send retrograde blood flow through the affected vertebral artery. This is called subclavian steal syndrome. Going back to the table, we have some important anatomic locations related to the subclavian artery listed in this middle column. The left subclavian artery arises directly from the aortic arch, while the right subclavian artery branches from the brachiocephalic artery. And as we just discussed, occlusion to the proximal portion of the subclavian artery will result in subclavian steal syndrome. Now let's talk about the intercostal arteries. So we can see the internal thoracic artery labeled here, and this gives rise to the anterior intercostal arteries. These arteries then travel along the ribs. Now the posterior intercostal arteries will arise from the descending thoracic aorta, right here. So blood will run through these posterior intercostal arteries and meet the intercostal arteries halfway, each supplying the ribs. Now this concept in anatomy is best demonstrated using aortic coarctation. Now aortic coarctation causes engorgement of these intercostal arteries, leading to rib notching. We'll dive into this concept more on a new slide. So aortic coarctation is a narrowing of the descending aorta. This decreases blood flow to the posterior intercostal arteries. In response, the anterior intercostal arteries will then supply the posterior intercostal arteries. In other words, blood travels from the internal thoracic, then to the anterior intercostal arteries, and then through the posterior intercostal arteries. So this retrograde flow through the posterior intercostal arteries will cause the posterior intercostal arteries to engorge and damage the ribs over time. On chest x-ray, you can see this as rib notching. Again, aortic coarctation is a narrowing that leads to decreased flow through the posterior intercostal arteries, but increased flow through the anterior intercostal arteries. After all, blood is able to travel normally through the subclavian artery and then down the internal thoracic artery. In fact, the left subclavian and the internal thoracic arteries actually get engorged, so their high pressure will lead to retrograde flow through the anterior and posterior intercostal arteries before reaching the descending aorta. And all of this engorgement of the posterior intercostal arteries will lead to rib notching. Going back to our table, with regard to the intercostal arteries, just remember there are anterior and posterior intercostal arteries. In aortic coarctation, there will be rib notching. Now let's talk about the internal carotid arteries and the external carotid arteries. We can see the common carotid arteries labeled here. Both the left and right common carotid arteries will split into the internal carotids, labeled here, and the external carotids. The basic principle that will be very useful is to remember that the internal carotid artery goes to the brain, while the external carotid arteries will supply the head and face, as well as the neck and nose. Using this figure again, notice that the common carotid artery splits into the internal carotid artery and the external carotid artery. The internal carotid artery continues up and supplies the brain. Going back to our table, just remember that the internal carotid artery supplies the brain, so its branches will be involved in brain pathology. For example, strokes will involve branches of the internal carotid artery, whereas the external carotid artery will supply the face, neck, and nose, and will therefore be involved in face, neck, and nose pathology. Notice that I have written that the maxillary artery is the main branch of the external carotid artery that you must be familiar with. The maxillary artery supplies many of these face, neck, and nose structures. For example, in cases of epistaxis or severe nose bleeding, think of branches of the maxillary artery. In the case of an epidural hematoma, think of a branch of the maxillary artery, the middle meningeal artery. Now let's do a question to apply what you've learned so far. A 30-year-old male presents to the emergency department following trauma to the nose during a snowboarding accident. Physical exam reveals profuse nasal bleeding. The damaged arteries resulting in this presentation originate from what vessel? Now recall that the arteries in the face, neck, and nose come from the maxillary artery, and the maxillary artery is a branch of the external carotid artery, which is choice B. Going back to the table, we can see that the external carotid artery supplies the face, neck, and nose, mostly via the maxillary artery, and most of the bleeding in this patient is likely from the medial nose, the nasal septum, where vascular density is greatest. Now let's talk about the arm, starting with the brachial artery. Notice as we follow the subclavian artery, it becomes the brachial artery. The brachial artery has several branches. The most important branch is the deep brachial artery, which I will come back to in a moment. Now, as the brachial artery travels down, it crosses the anterior elbow joint. This is super important to know, and here's why. When a person breaks their humerus, specifically down here near the joint, they are at a very high risk of damaging the brachial artery, which can be devastating. Notice in this image that the median nerve is also very close to the brachial artery. This means trauma to the brachial artery would also likely damage the median nerve. Associating the brachial artery with the median nerve is very high yield, so I will provide you with a memory hook after I discuss the next artery, the deep brachial artery. As you can see, the deep brachial artery crosses the mid-shaft of the humerus right here in the posterior portion. Okay. So keeping in mind its location, you can imagine that a fracture at the middle or mid-shaft of the humerus could likely damage the deep brachial artery. This also can be devastating to the patient. Arguably even worse is the damage to the radial nerve, which also crosses along the back of the humerus. The point is that damage to the mid-shaft of the humerus can damage the deep brachial artery and the radial nerve at the same time. Now I promised you a memory hook to help you remember these facts, and it is this: break before you hit the median, or you'll be in deep red blood. Again, break before you hit the median, brachial artery, and the median nerve, or you will be in deep red blood. Deep brachial artery with the radial nerve. Break before you hit the median, or you'll be in deep red blood. If you can remember that the brachial artery and the median nerve can be damaged together, and the deep brachial artery and the radial nerve can be damaged together, it'll help you a lot on board exams. Going back to our table, just remember that the brachial artery comes from the axillary artery, and it can be damaged with distal humeral fractures, and with it, the median nerve can be damaged. And the deep brachial artery branches from the brachial artery, and it can be damaged with mid-humeral fractures along with the radial nerve. And the memory hook is break before you hit the median, or you will be in deep red blood. The last point we need to discuss is the radial artery. So the brachial artery, which we just discussed, will then branch into the ulnar artery and the radial artery. Now the reason that the radial artery is so significant is because it has a branch that supplies the scaphoid bone in the hand, and it does this via the dorsal scaphoid branch. So when someone falls and lands on their outstretched hand, the scaphoid bone is prone to fracture. And to understand why a scaphoid bone fracture is so significant, you need to understand more about the artery that supplies it. So let's zoom in on this area. So this is the scaphoid bone. This part of the bone would be the distal portion, and this part of the bone is the proximal portion. The radial artery will descend down, and it branches off to supply the scaphoid bone. The specific branch is called the dorsal scaphoid branch, which you can see on the scaphoid bone. Now this artery is strange because it will supply the distal part of the scaphoid bone and then travel retrograde to the proximal part of the scaphoid bone. So here's the clinical relevance. If you fracture the scaphoid bone, the distal part will maintain adequate perfusion. However, the proximal part back here is at great risk of not maintaining adequate perfusion and is vulnerable to necrosis. Going back to our table, with regards to the radial artery, recognize that it branches from the brachial artery and then it branches into the dorsal scaphoid branch. And the clinical relevance is that scaphoid fractures can result in proximal scaphoid bone necrosis. Now let's do another question to apply what you've learned so far. An elderly patient is found to have vertebrobasilar insufficiency, resulting in frequent syncopal episodes. Extensive diagnostic evaluation reveals retrograde blood flow through the right vertebral artery directly into a major vessel. This major vessel arises directly from what artery? So hopefully you noticed that this patient has subclavian steal syndrome, as noted by the vertebrobasilar insufficiency and the retrograde blood flow through the right vertebral artery. Now, what major vessel is the right vertebral artery flowing into? Well, that would be the right subclavian artery, because we know that the right subclavian artery normally gives rise to the right vertebral artery. Okay, so we've identified the major vessel. Now the question is, this major vessel arises directly from what artery? So what artery does the right subclavian artery branch from? It's the brachiocephalic artery. Recall from this figure that the left subclavian artery arises directly from the aortic arch, right here, while the right subclavian artery arises from the brachiocephalic artery. So again, the answer to our question is the brachiocephalic artery. Now let's do one last question. A 15-year-old boy is involved in a car accident and presents to the emergency department with profuse bleeding from his left arm. He is unable to extend his wrist. A radiograph of the injured arm is obtained. Which artery is more likely damaged? The brachial artery, the deep brachial artery, or the radial artery? And lastly, what nerve is likely damaged? Hopefully you recognize that this image is showing a humerus with a fracture at the midshaft. Now, which artery is likely damaged by a midshaft humeral fracture? It would be the deep brachial artery. And what nerve is likely damaged? Well, from the physical exam, we are told that he cannot extend his wrist. So you may have determined that it is radial nerve damaged. You may have also remembered the trick we gave you. Brake before you hit the median, or you will be in deep red blood. And you would simply say, well, he damaged the deep brachial artery, so he must have damaged the radial nerve. And that concludes this section.